in. You probably think your insurance card is the cheapest way to buy your prescription, but for a huge number of common drugs, that's backwards. Paying cash can be cheaper than using the insurance you pay for every month. And here's the part that actually makes people angry once they learn it. For years, in many states, your pharmacist was legally forbidden from telling you that. Not because they didn't know, because their contract said they couldn't say it first. Well, that contract clause had a name. Pharmacists called it a gag clause. Today I'm going to show you exactly how that pricing system works, why it exists, and the completely legal discount network that lets you route around it. The same one insurance companies and pharmacy middlemen would honestly rather you never found out about. To understand this, you need to meet a player almost nobody outside healthcare has heard of. The Pharmacy Benefit Manager, or PBM, a PBM, sits between your insurance company and your pharmacy. It doesn't make drugs, it doesn't fill prescriptions. Its job is to negotiate what your insurance actually pays for medication and what you owe at the counter. 3 companies dominate this industry. Between them, they process the vast majority of prescriptions filled in the United States. Here's where it gets interesting. Your copay isn't necessarily based on what the drug actually costs. It's often a flat number your plan decided on in advance. Sometimes that flat copay is higher than the drug's real cash price. Researchers at the University of Southern California's Schaefer Center actually measured this. Looking at prescriptions filled in a single year, they found that in roughly a quarter of cases, what patients paid through insurance was higher than what the insurer itself was reimbursing the pharmacy for the drug. Overpayments added up to well over $100 million, just from people using coverage that cost them more than paying cash. So why wouldn't a pharmacist just say, hey, skip your insurance on this one, it's cheaper to pay cash, because in many contracts they weren't allowed to volunteer that. If the pharmacist offered that tip and the patient hadn't asked, the pharmacist could actually be penalized by the PBM. And reporters at the time ran headlines about patients paying $285 in copay for a prescription that cost $40 in cash. Because nobody was allowed to mention the cheaper option first, this is the part that surprises people. It sounds like it should be illegal. And as of 2018, at the federal level, it actually is. In October 2018, 2 bills, the Patient Right to Know Drug Prices Act and the Know the Lowest Price Act, were signed into federal law. Together they ban PBMs from using gag clauses that stop a pharmacist from telling you when paying cash beats your copay. Before that, more than a dozen states had already passed their own versions of the same ban. So legally, today, a pharmacist can tell you, the gag is gone, but here's the catch nobody advertises. The law says they can tell you. It never said they have to tell you first, without being asked. And most pharmacy staff are working through a line of customers with a point-of-sale system that automatically runs your insurance the second your prescription is entered. Nobody stops to manually compare that number against a cash price from a different network. It's not personal, it's just not the default workflow, which means the system didn't get fixed. It just moved the responsibility from the pharmacist's mouth to your mouth. You have to ask the question now. So here's the actual lever most people never pull. There's a second, completely separate discount network running underneath the pharmacy counter alongside the insurance one. It's built on the exact same PBM infrastructure, just aimed at cash-paying customers instead of your insurance plan. Companies like GoodRx and SingleCare aren't insurance, and they're not coupons in the traditional sense. What they actually do is shop your prescription across multiple PBM contracts that the pharmacy already has on file and hand you whichever negotiated cash rate comes out lowest. Marketplace, the public radio business program, reported on exactly how this works. When you use one of these cards, the pharmacy pays a small transaction fee to a PBM, and that PBM shares a slice of that fee with the discount card company. GoodRx doesn't set the price itself. It's surfacing a rate a PBM already negotiated, one your insurance plan simply isn't part of. That's why the discount can look absurd. GoodRx has shown common generics selling for a small fraction of the pharmacy's regular cash price, not because the pharmacy is losing money, but because that lower price was always available through a different network. You just weren't being routed to it. There's also a third option worth knowing, especially for people without insurance at all. Cost Plus Drugs, the online pharmacy that publishes its markup formula openly, manufacturing cost, plus a flat percentage, plus a pharmacist fee, with no PBM middleman involved at all. It won't have every drug and it ships rather than filling same day, but for the medications it does carry, it's worth checking as a baseline. None of this is a hack. It's not a loophole in the sense of exploiting a mistake. These are fully licensed, fully legal discount programs, built and operated in partnership with the same PBM system that sets your insurance price. You're not tricking anyone. You're just using a second public price list that the industry built for cash customers and simply never leads with. One important rule to understand before we go further. You generally cannot combine a discount card with your insurance on the same fill. It's one or the other per prescription, and you get to choose which one is cheaper. Here's exactly how to use this the next time you're at the counter. Step 1. Before you hand over your insurance card, open GoodRx or SingleCare on your phone and search the exact drug, dosage, and quantity your doctor prescribed. Both apps are free, with no membership required for the basic price search. Step 2. Compare both apps. They contract with different PBMs behind the scenes, so prices genuinely vary between them. Sometimes by a few dollars, sometimes by a lot more. Checking both takes under 2 minutes. Step 3. Compare whichever price is lowest against your insurance copay. Your pharmacy or insurer's app will usually show you the copay before you even arrive. 4. If the discount card price is lower, tell the pharmacist directly. I'd like to use this discount card instead of my insurance for this prescription. Show them the coupon on your screen or have it printed. They'll run it manually. It's a routine, everyday transaction for them, not a special request. Step 5. If you do have insurance and paid cash by mistake, ask about reimbursement. Some plans allow you to submit a cash receipt for partial reimbursement, especially if you hadn't met your deductible yet. It's not guaranteed, but it costs nothing to ask. One caution: cash payments and discount card payments typically do not count toward your insurance deductible or out-of-pocket maximum. For a cheap generic you take occasionally, that trade-off usually doesn't matter. For an expensive medication you're relying on to eventually hit your deductible, run the math both ways before deciding. That's the entire system. No accounts to fight over, no fine print to violate. Just checking a public price list before you check out. None of this required breaking a rule. It required knowing a rule existed. That's really the pattern behind most of these systems. Healthcare, insurance, finance. The default option isn't always the cheapest one, and the people running the system have very little incentive to point that out. The tools to opt out are usually sitting in plain sight, published, licensed, completely legitimate. Most people just never think to look. Next time you're standing at the pharmacy counter, that's the one question worth asking before you hand over your card. Is this actually the cheapest way to pay? If you found this useful, hit subscribe, and I'll see you in the next one.